Thank you so much for that testimony. And I do have a series of questions, and I believe a few of our members do as well. I did want to start off discussing a few pieces, and then I'll likely defer to some of the members of the committee to continue and then come back to a few things. I wanted to delve a little bit into some of the changes in Article 12, and specifically a few kind of finer points there. So looking into the Category D, so the SSI payments, there's a proposal here to eliminate those Category D payments. And I was curious if we knew how many facilities were impacted by this, and was it material to any? I'm going to assume no, given the size of the overall impact, but I did want to ask if it was a material change for any particular nursing home in that group. Or I should say assisted living. I'm sorry.
No, thank you for that. Thank you for the question. And yes, assisted living. Getting an echo. Sorry.
Hopefully it goes away.
Okay. The short answer to your question is we don't believe it to be impactful to facilities. We designed the initiative to be positive for all assisted living residences. In other words, they would get at a minimum what they already get, but actually increase both in Category D and Category F in tiered rates. So even in the basic tier A rate, the lowest acuity rate, they would receive $78 a day versus the current Category D rate of $69. And then importantly, we also made sure that individuals receiving state supplements, in other words, in particular former Category F recipients, would not see any net change in what they had to keep in their income or take home when they're in an assisted living residence. So I know you asked about Category D, but we looked at it both from the facility side and from the residential side.
Thank you so much. And then related to the nursing home rates, I certainly understand the piece there, and I think your presentation actually made it come to life a little bit more around the intent there to sort of put some more emphasis on behavioral health care. And I certainly understand that. But I guess my question would be, by increasing that weighting and effectively reducing rates for other categories, do we think that those rate reductions for other categories of nursing homes could be supported, or would it be more prudent to perhaps increase the weight on the behavioral services, but at the same time, increase some funding into that bucket there to ensure that there's no rate reduction felt by anybody, but we're incentivizing the behavioral services?
Certainly, increasing the rate specifically for behavioral health, as I mentioned, without an offsetting reduction is perfectly plausible. We make sort of trade-off choices in putting together the governor's recommended budget and having sort of a balance within that, and felt that the offsetting RUG scores, RUG changes, would be offset primarily by the cost of living adjustment increases that nursing facilities are getting. Because we're rebalancing the rates across every other RUG grouping, or essentially category of patient acuity, the reduction is in other rates is quite slight. But certainly, if the General Assembly wanted to amend that to simply increase the behavioral health RUG rates, that would similarly achieve the kind of policy outcome that we are going forward, which really is to make sure that nursing facilities have the resources required to provide quality care for individuals with these kinds of symptoms who may no longer be able to be cared for in the community.
And do we know, have we done any runs on what the cost would be to sort of just add the weight and not reduce the other rates in that rebalancing?
I believe we have. I don't remember the number right off the top of my head, so I'm happy to take that as a follow-up and provide that to the committee.
No, that'd be great. I appreciate it. And my last question before I maybe ask some of the other members to jump in, related to the graduate medical education element. I do know this is a program that has allowed us, and actually more recently, allowed us to bring in additional federal dollars into this space as well. I guess my question would be, why would we be seeing this as a program to reduce or eliminate versus actually one to expand to more of our hospitals and drive more of this funding into them and specifically more of the Medicaid funding into the state?
I think certainly there are states that target their GME payments in more specific ways, particularly towards harder to fill specialties, or actually lack of specialties, particularly primary care. We, as I stated, make sort of budget trade-offs throughout the governor's budget and within Medicaid, and certainly believe that hospitals are some of the better funded parts of our Medicaid system. And in recognizing that, put forward these items for consideration in the governor's recommended budget.
I guess, okay. I guess, let me ask that to be more simple. Are we giving up federal money that we shouldn't be giving up that could be going towards hospitals by eliminating the program in its entirety?
I think that the direct answer to your question is yes. I mean, if we do not provide the federal match for GME, we won't get the federal participation. I would just note that's much more recent sort of amount, and we only within the last year, I believe, began claiming a federal match for these. They sort of became allowable. But the direct answer to your question is yes, we'd be foregoing federal financial participation in these payments.
Yeah. I think I'd add just a little bit, which is basically, every change we have in Medicaid forgoes federal Medicaid dollars coming in. So, it sort of begs the question if we could make, any changes in the Medicaid budget. This was one area that, didn't directly affect patients and didn't directly affect those that receive Medicaid benefits, and affects a very small proportion of the hospitals in the state. That being said, as the director mentioned, it's certainly always a trade-off when you look at different budget proposals within the constraints we have.
Yeah. No, I certainly take that point, Director. I think it's fair. I guess my only real question on this one, and I think when we find other ways to be more efficient or reduce costs, I mean, that's is great. This one I think is, literally preparing the medical workforce. Now, and I also do agree with your point there around today, it's limited in a way that it's only one of our hospitals. And, as someone who was a 3-month preemie born in the NICU at Women and Infants, there's certainly needs in other hospitals as well, besides Rhode Island. And I guess, my piece there is this is a lever that we could have in our arsenal if we chose to have it, to work on some of the education prep there. And so just want to be cautious around thinking that through before we potentially take this as a savings item. Okay. Let me ask a few members of the committee if they have any questions or comments at this time. Director Woolman, you are lucky that Senator Paula had to step out of the room for a moment.
Thank you, Mr. Chairman. Yeah. If you could lock the doors, that'd be appreciated. Just kidding. I'm just kidding. I'll hear about that from Senator Paula later.
I think it's a great idea.
He had another commitment for about 15 minutes, and we're in that 15-minute window, of course, this evening. Are there any questions from the members of the committee, or I have a few more that I'm going to get to before we begin witnesses of the administration? Okay. A couple other things related to the Medicaid expenditure report. Talk to me a little bit about this. I know we didn't complete it. We were using an outside firm. Now we say we want to complete it internally. What's our confidence level that, one, we have the skill set and the capability to complete this report? Also, happy to hear what you believe is the usefulness of it. Do we feel that, it's driving a value? Would just love more context on the administration's view on this expenditure report.
Sure. So I'll start by why we think we can take it in-house and then comment on the usefulness of the report. We believe we can take it in-house because most of the queries and the sort of work are generally speaking complete, and that's something that the state can take over.
No.
That obviously begs the question. Well, then if the queries are written, sort of why is it taking so long? There were additional requirements that the General Assembly added to the expenditure report that are leading to the delay in this particular case. But should the report remain constant, most of the work is initially for doing that report rather than the reproduction. As we in a normal budget time sort of try and stagger this, so we're asking, I think, for 3 additional months within the year to complete that, essentially to spread out the finance team's workload in doing this, sort of generally speaking, sort of not around the same time we're preparing budget initiatives or caseload commentary and the like. In terms of the usefulness of the report, we think it's extremely useful. And in particular, it gives a more detailed understanding of where Medicaid funding goes, cost growth or cost savings, in a way that is a little bit more digestible to members of the committee, members of the General Assembly, and the general public. There's always more kind of data questions or spending questions you can ask. Particularly as it goes into Medicaid rate setting with our managed care organizations and the like, and certainly we do a lot of that through a variety of processes. But the Medicaid expenditure report is one of the sort of now set ways in which that information can be presented to the public. So despite the initial delays this year, we do believe it's a valuable report. It is a difficult one to produce. In the past, it's quite technically complicated, but one can argue that's why it's useful.
Okay. Thank you. That's helpful. I appreciate that. Okay. And then I do want to flip for a moment to some of the Article 14 items, and specifically related to the dish payments and the hospital licensing fee. As we think through that, I think the nature of this sort of item is something that I think has been an ever-changing, set of a rule book or guidepost from the federal government as to the direction that the federal government would be going in. And I think that's an important context for us in the committee to have, is that, I think actions that we had previously taken were in light of anticipating that the federal government would proceed with the dish elimination, and therefore it made sense for us to start bringing that licensing thing down as the dish money would go away, and would kind of look to phase that in over time. Since that's actually happened, there's been several moves by Congress, right, to extend the life of the dish payments. Also have moved to increase some of them, and also some of the adjustments there. Can you just briefly, talk to the intent of why we would amend the current year licensing fee plus next year's back to the 6% that it was previously, and then also how that correlates into ensuring a maximum federal dollars coming in via DISH and via some of the other changes that were recently passed by Congress?
So, Mr. Chairman, I think I'll start for a minute, and then maybe Director Shaffer can chime in. I mean, this has been a difficult year for all of us, but particularly healthcare providers. And, the federal government, over the course of 5 or 6, I'm even losing track now, stimulus bills that have been passed, increased hospital funding, I think in the state of Rhode Island, around $210 million. In addition, the previous administration started the hospital assistance program that Director Shaffer mentioned, that added on using Rhode Island flexible stimulus dollars of another $210 million to the hospitals. And we really wanted to, make sure we were providing a very solid fiscal foundation for the hospitals within the course of the last 12, 13 months. And even more recently, as Mr. Chairman, you allude to, in December in the stimulus, Congress made changes to the disproportionate share program and stopped its slow elimination that was actually started under the Affordable Care Act, or first proposed under the Affordable Care Act, under the idea that if we had a higher insured population in the state, or all states rather, that this payment of uncompensated care from the federal government to hospitals was no longer necessary, and that it would be faded out. Now, it's, as you've mentioned, been put off a few times and been back and forth, and was scheduled again to start going away. But in the December stimulus bill, it was put back, and the governor's budget proposed fully funding that, because it is certainly a very large amount of money coming into the hospital system and Rhode Island more generally. So we are fully funding that. So we pay about 50% of it. So that's another $70 million to the hospitals that was unanticipated when we put together the FY21 budget, and it was enacted by the legislature. So looking at additional 70 million, about half of that again being general revenue, we thought it was prudent to then re-increase the hospital licensing fee back to its historic levels of 6%, which has an impact on the hospital system a little bit less than $70 million. And this relationship between the hospital licensing fee and the dish payment it goes back for a very, very long time in all states, about having these two linked. They're not linked from a direct policy at the federal level, but they are linked on an operational practice at states. And so we felt that we were coming out a positive with that relationship. When you look at the amount we're adding for dish, and then the amount we're essentially taking away for the hospital licensing fee. The hospital licensing fee for 21 is paid at the end of the year, so we felt that this gave the General Assembly ample time to make that change. And in addition to the FY22 payment, that again becomes sort of equivalent to the dish payment.
And Director, on that point, sure. I just want to make sure I have something clear. So the FY21 current budget year dish licensing fee payment would be received by the state in July 2021, and it would count towards fiscal year 2021, if I'm correct.
Yes, that's my understanding. Director Shaffer, do I have that right?
Yes.
Yeah.
Okay.
So we felt like there was ample time to make that legislative change, and especially given the unanticipated December money from DISH.
Okay. And just, I'm just looking at the numbers that I have, and I just want to confirm these out, right? So the plan that was included and assumed in November revenue estimating conference had the 5%, licensing fee, and then had, the DISH levels at where they were. Licensing fee was about 161 million. DISH to hospitals was 71. Moving forward, the current proposal would be a 6% licensing fee, so it moves that to 193 million, but also moves the dish up to 142 million. So on a net versus November expectation perspective, it would drive a $38 million differential to the hospitals that would have otherwise not been assumed. Is that a fair assumption? Right, the hospitals are
I don't have the totals in front of me, and maybe Director Shaffer, you do. But the dish increase is about 70 million, and then the hospital licensing fee decrease is around the mid 60s. So there's a net positive impact, but over the 2 years, the differential between those two is less than $10 million.
Okay. The numbers I'm looking at, you can certainly come back and look at it. I'm just looking at hospital licensing fee goes up 32 million, dish to hospitals goes up 70 million, net impact to hospitals is 38 million favorable to hospitals.
So so you got to have the 21 and the 22. You need to look at the 21 and 22 hospital licensing fee increase.
Okay.
If you want to, compare it to the full legislative proposal.
Thank you. Okay. Are there any other questions or comments from members of the committee? Okay. Saved by the bell, Director Womer. We have a series of individuals signed up to testify on Article 12. I will ask the administration to hang on just a bit. I think a couple members of the committee may be coming back, and if members of the committee do have questions, I do want to make sure that we give them the opportunity to do so. The first witness that we do have signed up to testify on Article 12 is Ashley Sadler with Beata Home Healthcare in opposition to Article 12. And Ashley, welcome to Senate Finance.
Hi, thank you so much. Thank you, members of the Finance Committee, for allowing me the opportunity to provide testimony today. My name is Ashley Sadler. I'm the Director of Government Affairs for Beata Home Healthcare. I'm also the Secretary-Treasurer for our trade association, the Rhode Island Partnership for Home Care. Beata is a nonprofit national home care company that strives to provide the highest quality of nursing, rehabilitative, therapeutic, and assistive care services to Rhode Island's children, adult, and seniors in the comfort of their own homes. In Rhode Island, we have 4 offices in which we employ more than 400 healthcare professionals who deliver necessary and life-saving home care services to more than 500 clients across the state. We believe our clients and our families deserve home health care delivered with compassion, excellence, and reliability, Beata's core values. We are asking you to consider including the language within House Oversight Committee Chair Patricia Serpa's Bill 5793 as a more appropriate rate modifiers for Medicaid fee-for-service home care. There's 2 factors in here I'd like to just touch on. This bill would ensure that Medicaid fee-for-service rates are set as the price floor for other state-funded programs such as Medicaid managed care through the commercial insurance carriers, PACE, and the Office of Healthy Aging copay and respite programs. By ensuring that providers are not reimbursed for services below the state's current fee-for-service rates, home health care providers will be able to continue to provide wage growth for our frontline workers and expand the availability of our workforce. It is especially critical that we are able to incentivize them to provide care during currently difficult to cover shifts and more towards meeting the state's long-term care finance rebalancing goals. We are also seeking a 10% rate increase to incentivize more nurses to pursue enhanced training to deliver care to the state's highest acuity patients. Currently, providers struggle to staff the most acute medically fragile cases, as home care nurses can typically make the same or similar wage for providing care to clients that have lower acuity care needs. A rate increase would allow for adequate coverage of such cases and therefore decrease hospitalizations and ER visits, which are currently charged to the state's Medicaid program because of providers' inability to staff such cases. Thank you for your time, and please contact me or the Rhode Island Partnership for Home Care with any questions you may have.
Thank you so much, Ashley, for your testimony. Are there any questions or comments from members of the committee? Hearing none, Ashley, thank you so much for your testimony today.
Thank you. Have a great night.
Thank you. Elise Wilkie is next to testify, representing herself in support of Article 12. Elise, welcome to Senate Finance.
Hi, thank you everyone for having me. My name is Elise Wilkie. I am a birth and postpartum doula here in Rhode Island and also practice in southern and coastal Massachusetts. I approve the doula bill and just calling to show my support. The different ways the doula bill can help actually lower the maternal cost of care is that doulas are the first line of contact when working with perinatal families. So things that can arise where we're entirely non-medical, if a birthing person or pregnant person mentions to us kind of telltale signs of things that maybe they have a headache, maybe they've been feeling dizzy, that's the moment that we can now tell them to call their provider, call the doctor, get them in to see a specialist and help make sure that small things don't have to become larger issues later on. So again, though we are non-medical, we are that first line of contact, seeing different issues coming up, letting them know whether that's common or normal or something they should talk to a doctor for. So in the long run, the doulas are able to save insurance companies an incredible amount of money by being that first line of contact, giving them the care they needed as soon as they need it, and not letting it be prolonged into this kind of bigger issue for the parents, for the birthing person, for everyone in general. So again, just want to fully support the doula bill. If anyone has any questions, I'm happy to answer them. But in the long run, having a birth doula present with the family, because usually families are hiring us by maybe month 5, month 6, if not earlier. So sometimes we're caring for them their entire prenatal period. And again, a doula being there and being that first line of contact and having that information, being non-medical, we always send them off to their doctor so that things can get taken care of right away and don't snowball into a larger issue. Again, thank you for your time.
Thank you.
Thank you so much.
Thank you so much, Elise, for your testimony. Are there any questions or comments for Elise? All right, hearing none. Thank you so much, Elise.
Thank you. Have a great night.
Next to testify is Sarah Espinal, representing herself in support of Article 12. Okay. Sarah, we were unfortunately not able to reach, but she was signed up to testify in support. We also attempted to reach out to Linda Katz of the Economic Progress Institute in support of Article 12, and also Michael Bigney of Home Health and Hospice Care of Nursing Placement, also in opposition to Article 12, but unfortunately we're not able to reach them. We do have Leanne Spears representing herself in support of Article 12. The committee would just stand at ease for just a moment. Okay, so for the committee's knowledge, we've attempted to call several individuals. I'll read off who we attempted to call and their position. Victoria Picnic, representing herself in support of Article 12. Charlotte Lee, representing the Warren Alpert Medical School at Brown University in support of Article 12. Emmanuel Falk with SEIU 1199 New England in support of Article 12. And we do have on the line to testify Caitlin Arona with Rhode Island Kids Count in support of Article 12. Caitlin, welcome back to Senate Finance.
Hi, thank you again for having me. I would like to offer Rhode Island Kids Count strong support for Budget Article 12, Sections 8, D, J, K, C, and E, which allocate funding for perinatal doula services, family home visiting, silver diamine fluoride treatment, and community health workers. Rhode Island Kids Count is a leader of the Right from the Start campaign, which supports expanding access to doula services and family home visiting. So first, I'd like to talk about perinatal doula services. In Rhode Island between 2014 and 2018, 16% of all women received delayed prenatal care. However, this statistic masks significant racial and ethnic disparities. Within that same time frame, Black women in Rhode Island were 40% more likely than white women to receive delayed prenatal care. And Black women in our state were significantly more likely to experience an unintended outcome of labor and delivery that resulted in significant consequences to their health. Unfortunately, in addition, Black infants in Rhode Island die in the first year of life at a rate nearly 3 times that of white infants. A growing body of evidence indicates that pervasive racial bias against Black women and unequal treatment of Black women in the healthcare system often results in inadequate treatment for pain. So this, coupled with stress from racism and racial discrimination experienced throughout the lifespan, contributes to unacceptable health outcomes that we see among Black women and their infants in our state. Doulas have emerged as a key method of addressing these disparities in both maternal and infant morbidity and mortality by delivering a higher quality of culturally appropriate and patient-centered health care for women, particularly those who are low-income women or women of color. For those who may not be familiar with doula services, a doula is a trained professional who provides physical, emotional, and informational support to mothers before, during, and immediately following childbirth. Support from a doula during labor and delivery is associated with improved health outcomes for both the mother and their baby, including shorter labors, lower C-section rates, and higher 5-minute APGAR scores, all of which is backed by rigorous scientific studies. So moving on to Medicaid home visiting, Rhode Island's First Connections program is an essential part of our state system to support families with newborns and young infants and to connect them to programs that will help their children thrive, such as early intervention, Head Start, or other high-quality evidence-based family home visiting programs. In 2009, in Rhode Island, over 2,200 families with new babies received at least one First Connections visit, almost a quarter of the families who gave birth in the state. Adding prenatal visits will help families get help sooner so that families can be on more stable footing when they bring their babies home from the hospital. Over the last decade, Rhode Island, like many states, has developed a system of evidence-based family home visiting programs using federal funds. These national model programs, such as Healthy Families America, Nurse Family Partnership, and Parents as Teachers, have all been rigorously evaluated and are proven to improve both child and parent outcomes. Rhode Island has been providing limited Medicaid coverage for only 3 visits for the Healthy Families America and the Nurse Family Partnership programs. We need to extend the number of family home visits covered by Medicaid to cover the entire length of the programs. Rhode Island Kids Count supports the plan to add parents as teachers onto the list of evidence-based programs covered by Medicaid. However, we also encourage the state to increase the Medicaid rates paid for home visits so that the nonprofit agencies that operate these programs are more financially stable and can offer more competitive wages to attract and retain highly skilled family home visitors. And lastly, we also support Section C and Section E, which are outlined in my written testimony for you. And that's it.
Thank you so much, Caitlin, for your testimony. Are there any questions or comments from members of the committee? Okay. Hearing none, thank you so much, Caitlin. We appreciate it.
Thank you.
Next to testify is going to be Sam Salganic, representing Rhode Island Parent Information Network in opposition to Article 12. Sam, welcome to Senate Finance.
Hello, can you hear me?
We can.
Mr. Chairman, members of the committee, thank you for having me. My name is Sam Salganic, and I'm the Executive Director at the Rhode Island Parent Information Network, or RIPEN. Speaking today to oppose the proposed cut to our care management program that works with vulnerable, older, and disabled Rhode Islanders and helps them live safely and independently at home. I want to thank Director Shaffer for calling out this cut in his presentation and mentioning it as something that they're recommending be revisited. I'd also like to thank him for demonstrating in slides what I can't demonstrate in slides over the phone, which is that Rhode Island historically has done a poor job in its balance of investments in long-term care in terms of the balance between community-based investments and facility-based spending. It costs the state about $65,000 a year to care for someone in a nursing home, and it costs on average about a quarter of that to care for someone at home. And most patients prefer to be at home. Our program at RIPEN works with dual eligibles, so these are people who have both Medicare and Medicaid coverage. And for this population, the state program, Medicaid, is primarily responsible for paying for long-term services and supports. That's home care or nursing home care. So we work with dual eligibles who are very high need or high risk. We connect with them and support them with community health workers, supported by a clinical care management team, licensed nurses, and social workers. And we connect these individuals to the resources that they need to live at home, healthy lives, independent lives, and stay out of facilities. Our patients love the work that we do. 97% are satisfied. 100% report that their care manager treats them with respect. This program is relatively new. It was created 2 years ago. It's part of a critical state goal in terms of rebalancing long-term services and supports. It's built on best practices from other states. It's lower cost than some other options that were considered at the time. And we would respectfully submit that now is not the time for a circa 25% cut to this program. RIPEN is a 30-year-old community-based nonprofit. We are peer-led, so a majority of our board and about 3/4 of our staff are parents or caretakers of a loved one with a special health care need. And I'd like to thank you for the opportunity to submit this testimony.
Thank you so much, Sam, for your testimony. Are there any questions or comments from members of the committee? Senator Acosta.
Sam, thank you for your testimony today, and Chairman, thank you for the opportunity to ask a question. And I had this question, frankly, also of the directors. I'd like to ask Sam first, given his expertise and work in this area. And it's easier to throw other states under the bus, so let me do that. I grew up in Florida, and it's a place where we've seen this kind of exploitation of how we create a market for home-based care. And we know that people are more comfortable at home, but then we also have high rates of fraud. And we've made people in some ways a commodity. So I was actually just in another state, New York, where as you're driving in the car, you're listening to the radio, you hear these ads for, with your funding, you could get coverage provided by someone of your choosing, which on its face seems super accommodating, but in practice could lead to a very predatory kind of neoliberalization of home health care support and of support for people. So what's the right balance in your experience between the kind of brick and mortar institutional setting and the home setting that doesn't take perverse advantage of the market approach to it?
Thank you, Senator. That's a great question. At RIPEN, we always try to start with the patient preference, the patient and, of course, their family and loved ones who are helping care for them. What we hear from patients, and I think we're not unique in this, is that many prefer to age at home and feel like they do better aging at home if they have the right support in place. Historically in Rhode Island, and maybe other states too, For various reasons, it can be more difficult and more complicated to set up the supports at home than it is to get access to facility-based care. And that has created this skew over time where Rhode Island is ranked 42nd and is about 3/4 of the spending goes toward institutions. Rhode Island has had a long-term goal of getting to around 50-50 in terms of spending on long-term services and support. That would end up ranking Rhode Island, 10th, 11th, 12th, something like that. And I do think that goal, if Rhode Island got to that goal, it would be meeting the preference of more patients than it is today. I hope that was helpful.
Certainly, thank you. Appreciate that.
Thank you so much, Senator and Sam. Are there any other questions? Okay, hearing none. Sam, thank you so much for your testimony this afternoon.
Thank you.
Next testify is going to be Charlotte Lee with the Warren Alpert Medical School of Brown University in support of Article 12. Charlotte, welcome to Senate Finance.
Thank you so much. Charlotte Lee. I'm a fourth-year medical student at the Warren Alpert Medical School of Brown University. I completed my undergraduate degree at Duke University in public policy, and I'm here to testify in support of Budget Article 12, Section 8D regarding perinatal doula services. I think this is a really incredible opportunity to take evidence-based action against the maternal morbidity and mortality crisis, particularly among Black and Indigenous patients and other patients of color. Starting in June, I will be an OBGYN resident, and it's really important to me that we use the best available evidence and research to inform how we take care of patients. And the higher standard of evidence is systematic reviews, and Cochrane is the organization that's best known for the most rigorous systematic reviews that combine all available published evidence on a topic to determine if there truly is an effect. And there actually is a Cochrane review study on continuous support for women during childbirth that included more than 15,000 patients in labor from more than 17 countries, which showed definitively a decreased rate of C-sections, vacuum or forceps births, need for analgesia or epidurals, among other positive outcomes for baby and mom. Decreasing the rate of C-sections inherently decreases the cost of care and the rate of surgical complications, which can be life-threatening, including infection, hemorrhage, and blood clots. And so through emotional support, comfort measures, positioning, massage, coping techniques, and patient advocacy, doulas provide continuous labor support, which improves patient and infant outcomes, along with patient experience. And I just think if there was a pill that could improve the outcomes the way that doulas do, we would be giving it to every single patient. Beyond the evidence, I'd just like to share a brief experience with my family with doulas. I was actually born healthy, spontaneous vaginal delivery as a result of doula care. My mother first had a C-section that had infection with postpartum depression, and her first labor, she said, felt like being in the military, where she was told, you must get this treatment, you must be in bed, you must be laying down. She felt like she had no control, and she never wanted to have that experience again. Her doctor recommended a doula to give her the best chance at having a vaginal delivery after a C-section, and she was lucky to be able to afford doula care. Her doula offered calm, powerful encouragement, suggested different positions to labor in, provided therapeutic massage, and helped my father be a better support person. And she said without a doubt she felt less pain, less anxiety, and is not sure that she would have been able to deliver me naturally without her doula. I think that everyone deserves a doula and a birth experience with less pain, less anxiety, and with dignity. And as a future OBGYN, I'm going to do everything in my power to ensure that all of my patients have access to doula care, regardless of income, insurance status, or the color of their skin. So thanks so much for considering supporting Budget Article 12.
Thank you so much, Charlotte, for your testimony. Are there any other questions or comments from the committee? Hearing none, Charlotte, thank you so much. We appreciate it.
Thank you.
Next testify is going to be Paula Carmichael, representing Rhode Island Now, in support of Article 12. Paula, welcome to Senate Finance.
Hello, thank you for having me. My name is Paula Carmichael, and I am here representing Rhode Island Now, speaking in favor of doula care coverage. Can you hear me?
We can.
Great. Rhode Island now is urging you to support perinatal doula services in this year's budget. We really do need to improve pregnancy outcomes for Black, Brown, and lower-income women in Rhode Island. We have too many preterm babies and maternal complications in our state. I should let you know that I'm a physician and I've been on the board of directors of a $500 million HMO. And I'm very impressed with the efficacy and the cost efficacy of birth coaching / doula care. A large Midwestern study suggests about a 2-to-1 ROI for this care. Of course, exact numbers for Rhode Island would be different, but almost all scenarios do show substantial immediate cost savings would be predicted. For example, reproducing the Midwestern study's 22% reduction in our roughly 800 preterm births would translate to about $4 million per year savings in Rhode Island. Besides fewer preterm births, doula care is associated with lower rates of C-sections, shorter labor times, less anesthesia, fewer maternal and infant deaths, and fewer complications after discharge from hospital for both mothers and children. It seems clear that doula care at the very least pays for itself through improvements in preterm birth costs alone. However, in addition, substantial cost savings could be realized through decreasing C-sections and decreasing lengths of stays, lower costs in the year after the birth for healthier mothers and babies, and long-term lower costs resulting from fewer children needing special education. It is telling that the march of dimes is in favor of doula care. Premature babies can suffer lifelong effects such as cerebral palsy, mental retardation, visual and hearing impairments, and poor health and growth. Babies born only a few weeks early are at risk of long-term learning difficulties. Healthy babies translate to healthier 5-year-olds, 10-year-olds, and 15-year-olds, and eventually 50-year-olds. I think, and we think, that providing doula care during the critical stages of pregnancy can make a lifelong impact for the tiniest Rhode Islanders and their families, which can improve our state for decades to come. We think that saving lives, saving money, and putting babies on track for lifelong better health is a three-way winner for Rhode Island. Thank you for your time.
Thank you so much, Paula, for your testimony. We do appreciate it. Are there any other questions or comments from members of the committee? Hearing none. Paula, thank you so much for testifying with us this evening.
You're very welcome. Bye-bye.
Thank you. Next. Will the committee just stand at ease for just a minute, please? We had two individuals that did sign up to testify what we were not able to reach. Cheryl Levesque with Home Care Advantage in opposition, and Vincent Ward with Home Care Services of Rhode Island in opposition. We have to testify Robert Marshall with the Rhode Island Developmental Disabilities Council, who's not taking a position but speaking on Article 14. Robert, welcome to Senate Finance.
Thank you, Chair Pearson and members of the Senate Finance Committee. Here on behalf of the Rhode Island Developmental Disabilities Council and the Rhode Island Developmental Disabilities Council strongly request that the Senate Committee on Finance and the full Senate give serious consideration to adding an article to the 2022 budget, establishing funding and staffing a commission to develop an Olmstead plan as part of your review of the EOHS budget articles. I've submitted fairly extensive written testimony on this, and so I'll try to be as brief as possible. Olmstead, as most of you probably know, refers to the U.S. Supreme Court's 1999 decision that said that individuals with disabilities have a right to live in the most integrated setting permitted by their disability. And gaps in the continuum of care in Rhode Island for continuum of care available to Rhode Islanders with disabilities leaves many of them without the ability to choose the least restrictive option for receiving support services that they need and are entitled to. Over the last year, a coalition has been working on that was led by the Mental Health Association of Rhode Island, has been working to develop a proposal for the development of an Olmstead plan for Rhode Island. The coalition included representatives from Buddha, DCYF, Office of Healthy Aging, Office of Rehabilitation Services, MHARI, Governor's Council on Disabilities, the Rhode Island Developmental Disabilities Council, and Rhode Island Elder Info, the Sherlock Center, and many others. So the process was quite extensive, including some virtual town meetings, gathering as much data as possible, both from sources in Rhode Island and sources outside Rhode Island, and from literature, and then drafting and editing a proposal for the development of such a plan, which I attached to my written testimony for your perusal. Rhode Island right now is only one of 7 states that have not developed or adopted an Olmsted plan. And many of the difficult issues our state is trying to address today would have been included in an Olmsted plan had we done one earlier. Whether and how, that includes whether and how to downsize the Cranston and Barberville campuses of Ellen and Slater Hospital, how to address the problem of high percentage inmates at the ACI with serious or persistent mental illness, how to address the needs of homeless persons with serious and persistent mental illness, intellectual disabilities, and physical disabilities, or elders. The consent decree that we're trying to work out with the Justice Department, which resulted from the unnecessary segregating of people with IDD in sheltered workshops, and how services should be delivered to elementary and secondary students who are blind or visually impaired. We would have answers well planned out for all of these if we had done a plan when we should have years ago. As I stated, only 7 states are without an Olmsted plan, one of them being Rhode Island. The other states that have plans can be divided into 2 groups. There were those that took the initiative, developed the plan, and put it in place. And then there were those that were forced into a plan as a result of the U.S. Justice Department lawsuit. The Council urges you to move forward with this proposal for development of a Rhode Island Olmsted plan rather than wait for another lawsuit. I'd be happy to take any questions. I also spent quite a bit of time recently with one of your members, Senator Palmer, on this, and I'd be happy to do that individually with any of the other committee members that have questions, or I can take them now. Thank you.
Thank you so much, Robert. We appreciate your testimony this evening. Are there any questions or comments from members of the committee? Hearing none. Thank you so much, Robert. We do appreciate it. Next testify is going to be Lisa Tomaso, representing the Hospital Association of Rhode Island, in opposition to Article 6. Lisa, welcome to Senate Finance.
Thank you, Mr. Chairman. Am I set to go?
Please proceed.
Thank you. So thank you, Chairman and members of the committee, for the opportunity to speak on the proposed budget articles tonight. I am Lisa Tomaso, the Vice President of Strategy and Public Relations for the Hospital Association of Rhode Island. Harry and its members appreciate the support that the General Assembly and the Rhode Island Executive Office have provided to hospitals and health systems in Rhode Island over the past 13 months as we face the unprecedented healthcare and economic challenges of COVID-19. Although we are grateful for the governor's recommended Medicaid rate increase in FY22, we are disappointed that the governor's proposed budget includes a retroactive license fee increase from 5% to 6% for FY21, a license fee increase for FY22, and other hospital payment cuts. We recognize that the governor's proposed budget was introduced without the benefit of the federal stimulus funds made available to states by the American Rescue Plan, and appreciate, as mentioned by Director Shaffer, that in his letter to the General Assembly, the governor proposed reversing the hospital license fee increases if the state received stimulus funding. We know there are many difficult choices that need to be made in the development of the state budget. However, if adopted, these proposals will be detrimental to hospitals and the Rhode Island economy. The governor's recommendations would cost hospitals nearly $70 million. The financial impact of the FY22 recommendations on hospitals and the retroactive provider tax increase recommended for FY21 will further challenge hospitals to meet the needs of the community as we begin to move from response to recovery to rebuilding from the pandemic. The latter provision, the retroactive rate increase representing $32 million, is actually due weeks after the General Assembly passage of the FY22 budget, and is particularly harmful as some hospitals continue to run negative operating margins. And it's also important to note that for the state, the tax increase represents an increase in the FY21 state budget surplus carried forward to balance the proposed FY22 budget, not funds necessary to close an FY21 budget shortfall. So while we appreciate the support and resources provided to hospitals by Congress and the state during the pandemic, these funds were necessary to ensure that hospitals could keep their doors open to meet all of the healthcare needs of Rhode Islanders after the shutdown of all non-emergent elective procedures in March. The reality is hospitals in Rhode Island have a financial vulnerability that predates the pandemic. For years, our hospitals have had the slimmest operating margins in the nation, and in 2020, hospitals in Rhode Island limped into the pandemic with a collective operating loss of $23 million from 2019. Ongoing factors that contribute to the financial instability of hospitals include an imbalanced payer mix with 65 to 75% of patients at many hospitals being covered by the lowest payers, that's Medicaid and Medicare, uncompensated care costs that annually exceed $200 million, and yes, the provider tax. And I wasn't planning on making this statement, but it was part of the testimony provided by the state, that I wanted to make note that the state DISH program was established as a partnership between the hospitals and the state to maximize federal dollars to benefit both the state and hospitals. The hospital license fee or provider tax was created for this purpose, to help the state leverage state general revenue to maximize federal DISH dollars. And in listening to Director Woolmer testify to the benefit hospitals have gained in the FY21 budget, he did not mention the more than $250 million in uncompensated care provided by hospitals for which the federal DISH program was created. So in FY21 at 5%, the state will net more than $80 million after putting up necessary matching funds, while hospitals net at best a negative $242 million when uncompensated care is included in the relationship between the DISH payment and the hospital provider tax. The pandemic certainly has compounded the impact of these ongoing factors for hospitals, and similar to the state, hospitals will continue to be strained by the economic impact of COVID-19 for the foreseeable future. Hospitals continue to see increased costs for labor and PPE. Patients are foregoing basic care, which will affect resources, patient acuity, and the overall health of our population. And there have also been significant shifts in enrollment from commercial to Medicaid insurance. The Hospital Association and its members are grateful for the commitment of this committee and the General Assembly to put hospitals on a path to financial strength. We are asking for your continued support in that effort through a reversal of the license fee increases and restoration of other hospital supplemental payments. As always, we look forward to working with you and your staff to create long-term solutions to improve the population health and create efficiencies. Thank you for the opportunity to speak, and I'm happy to answer any questions you may have.
Thank you so much, Lisa, for your testimony. Are there any questions or comments from members of the committee? Senator Paula.
Thank you, Mr. Chairman. Just a comment, Lisa, thank you for all the work you're doing and helping educate us as well with regards to hospital funding. It's appreciated. Thank you. Thank you, Chairman.
Thank you, Senator. Senator Acosta.
Thank you for your testimony. I have a question. I'm less well versed in hospitals and funding than the Chairman De Palma is. So a very naive question. You talk about the struggles that hospitals are facing now, but because this is a tax that's based on how much you make in some ways, then wouldn't it just mean that if hospitals were struggling, that they would be required to pay less? Now, unless there's something wrong with your bookkeeping, in which case your revenues are made up much more of expenses than they are of profits, then it would be more of an internal problem. But on the outside, I guess, on the face of it, if it's a tax on what you bring in, then if you're bringing in less, you pay less. If you bring in more, then you pay more. And so what is the main stance against the tax?
So the tax is based on net patient revenues, yes. But our costs our expenses are against the costs of providing those services. I think that's the simplest way that I would be able to say that. If revenue goes down, do we pay less? Yes. So an example of that would be that we do see that the net patient revenue for FY 2020 is down approximately 5%. That means that even at the max, less will be collected by the state. So does that help answer your question, Senator?
Sure. I guess I just for a little clarification, I don't understand what the frustration is if we acknowledge that making less also means you pay less. And so is it that the costs are somehow higher than they would be under normal conditions right now, and so it's cutting into the profit side of the revenue, and that's something that the hospitals don't want? Or is it that under better circumstances, the association would be okay with being taxed at the federally allowed 6%?
So hospitals are, I in my testimony, provided you with statistical information that said that hospitals collectively ran a negative operating margin in 2019, and that was going into the pandemic. Our costs, or our net patient revenue, includes from our payers, which are Medicaid and Medicare, what they pay us for the services that we provide to patients. That reimbursement does not cover the cost of care. Medicaid, on average, hospitals lose 20 cents per dollar of care that is provided, and on Medicare, it's approximately 7 cents. There is not, what you're describing is correct, but it's not taking into account the fact that our payers do not reimburse us at the cost of the service. So essentially, it would be like a business having a product or a service that they want to put for sale for $10, and they can only get $8 for that product. And it's irregardless of what the demand is for that product in the market.
That's helpful. Thank you.
Okay.
Thank you so much, Lisa. Senator, are there any other questions for Lisa from the committee? Hearing none. Lisa, thank you so much for your time with us this evening.
Thank you, Chairman. Have a great night.
Thank you. Next to testify is going to be Lori Marie Piscata, representing the Mental Health Association of Rhode Island, speaking Article 6, but not taking a position. Lori Marie, welcome to Senate Finance.
Thank you so much, Chairman Pearson and members of the committee. Thank you for this opportunity. My name's Lori Marie Piscata. I'm the Executive Director of the Mental Health Association of Rhode Island, and we are a consumer advocacy organization. We focus on mental health policy, advocacy, research, and education. Senator Paula asked me to speak this evening. As this committee considers funding for the Executive Office of Health and Human Services, I'm here to ask this committee to consider establishing, funding, and most importantly, implementing a comprehensive living Olmstead plan for Rhode Islanders with disabilities. Olmstead refers to the landmark United States Supreme Court ruling, which held that under the Americans with Disabilities Act, individuals with mental disabilities have the right to live in the community rather than in institutions if it is appropriate for their disability and if the less restrictive setting is not opposed by the affected individual. So a comprehensive living Olmstead plan signifies a state's intention and good faith effort to comply with the Americans with Disabilities Act. And as Robert Marshall already mentioned, we are one of only 7 states that doesn't have any type of a plan or strategy. What makes this a living plan is that it's renewed every 5 years in perpetuity. So each 5-year cycle begins with a statewide needs assessment for people with intellectual developmental disabilities, serious persistent mental illness, physical disabilities, older adults, and youth at risk of institutionalization. So the assessment looks at the supply and the demand of housing options and the full continuum of care, home and community-based services, and supports. And so every 5 years, the state conducts a new assessment to see how the population has changed and what's needed. And then after the assessment, the state drafts a plan and then begins to address the most pressing needs for people with disabilities. So a good plan puts federal and state funding streams into place to invest in things like supervised and supportive housing options, transportation for people with disabilities, educational and employment support so that people with disabilities can get an education and be gainfully employed, affordable housing, home modifications, technology, durable medical equipment, everything a person with a disability might need to avoid institutionalization. So I've already emailed each member of this committee a policy proposal to establish an Olmstead plan. You will see on page 14, I've listed a number of possible funding sources. My email also included a recent article from the Providence Journal about a patient who is currently in Fatima Hospital who wants to live in a less restrictive setting, but he cannot because there's none available right now in Rhode Island. So he's stuck in an institution against his choosing. So this is a violation of the Americans with Disabilities Act, and I'm very concerned that Rhode Island's neglect of our continuum of care makes the state vulnerable to being sued. Alameda County in California is being sued right now for a similar violation of the ADA. And I truly don't want Rhode Island to be sued. The Mental Health Association absolutely will not sue the state, but you are vulnerable to being sued by other groups or an individual whose rights have been violated. There are clear disadvantages to being sued. I mean, first, the U.S. Department of Justice steps in and creates its own plan of correction for Rhode Island, and we may not like that plan of correction. And second, litigation is expensive, and that's money that could be better spent on housing and treatment options for our continuum of care. I respectfully and enthusiastically urge this committee to make an Olmstead plan to give people with disabilities everything they need to live their best lives. It's the right thing to do, and the Americans with Disabilities Act requires us to plan for people with disabilities and their needs. I respectfully urge you to put us on a path to establishing an Olmstead plan, and I am at your service to help in any way I can. I'm happy to answer any questions tonight or in future. Thank you for your time.
Just a comment.
Lori Marie, thank you so much for your testimony this evening. Are there any questions or comments from members of the committee? Senator Paula.
Thank you, Chairman. Thank you very much, Lori, for being here. But I apologize for missing Bob's and other previous testimony as I had to step out for an urgent matter to address. But Lori, thank you for bringing this forward. We do need to figure out how we establish and put into effect an Olmstead plan here in Rhode Island. So thank you for what you do, and Bob does as well. So thank you. Thank you, Chairman.
Thank you so much, Senator. Are there any other questions or comments from the committee? Okay. Hearing none. Lori Marie, thank you so much for your testimony this evening.
Thank you all. Have a great evening.
Thank you. At this time, we do have a few members that were able to rejoin the committee. I want to thank the members for being as flexible with this long hearing today. And I know several had commitments and members had to come in and out. So I do want to revert back to the administration. I believe Director Wolmer and others with EOHHS may still be with us. And I would like to revert back now to questions from the committee for the administration on these proposals. Senator Paula.
Thank you, Mr. Chairman. I have several, so stop me when you want to go to somebody else and we'll come back. So the first question has to do with the with UHIP, Unified Health Infrastructure Project. I'm not certain to whom this question should be addressed. At some point, not tonight, if we can get some insight into what remains regarding UHIP. I know we're looking at an overall price tag of just south of $700 million, not just EOHHS, but others. EOHHS is less than that. It's just south of $500 million. At some point, if we can get some insight to that, that's one request. A question regarding the follow-on support, and I'm not asking you to give me any details if you can't. With regard to the procurement for an RFP that would begin November 1st, the contract that would begin November 1st, can someone articulate where we stand in the process?
Senator, are you referring to the Rhode Island Bridges RFP?
The RI Bridges, yes. Basically, the RFP that we expect to have I think the RFP process is currently underway, and we're expect to have a contract in place by November 1st. So where are we in the RFP process?
As you mentioned, the state has engaged in a procurement process for what we call the maintenance and operations contract for UHIP. So obviously that is to continue to operate Rhode Island Bridges, which serves 300,000 plus individuals in the state as the eligibility system for all of our health and human services programs. It is a competitive bidding process, and as you mentioned, it's yet to be completed, so I can't provide many specifics, and that bid or eventual bid and contract also requires sort of federal approval. So since this is sort of the budget hearing, so I know that there's often questions about what we're assuming in the budget. The governor's FY22 budget reflects savings in the UHIP budget, which EOHHS bases off the information available at the time the budget's was being developed. Excuse me. And when that new contract is executed with whoever wins that M&O bid, we'll need to review, looking backwards. But I can say certainly we're remain in the process of that request for proposal around the maintenance and operations, as you mentioned.
So, Director, just maybe be a little more specific. Has the RFP? I'll make a statement based on what you said. I think the RFP is already out, and proposals have come back already, and we're in the evaluation stage, or they've not come back yet, the proposals?
The proposals have come back, yes.
Okay, thank you. I don't want to go any more than that. I just wanted to get a status of where we were, so, okay. Let me go to the next question. That has to do with I think Secretary Novice briefly talked to it, having to do with the HSTP, the Health Systems Transformation Project. And we had a hearing on this, not last year, I don't believe. I think it was in 2019. And I think it was just after Loretta Converse has left. She had left, and I think if Marty Rosenberg is working this now. And I know the majority of the money is targeted for AEs, the accountable entities. How do we, the General Assembly, get insight into the return on the investment of upwards of $240 million?
In fact, Senator De Palma, that is a question that Director Ben will need to address, as HSTP is within the Medicaid agency that he oversees. So I will turn to him.
Yeah. Thank you, Anna, and Senator, happy to address the question. And I'm the hearing I think you're referring to was last year. It was in 2020, and the reason I remember it is I think it was my third day as Medicaid director. Okay. And in February 2020, prior to the public health emergency, so it was one of the last hearings that we were able to do in person. the short answer to your question is that we provide, as they become available publicly, information on not just disbursements of funds from that health system transformation project that you mentioned, the $230 million of state and federal money going to establishment of accountable entities, but also, what accountable entities are doing with those fundings, and importantly, to your question, what we're seeing in terms of returns in quality and in total cost of care. Because of sort of lag delays and I should mention, we're currently finishing up the third year of the project. So shortly, not ready because they're still being sort of finalized, but shortly we'll have returns for project year 1 and 2, which really give us the first data on quality and cost in the program. So I don't want to jump the gun and give you incorrect or incomplete information, but I believe certainly by June is our aim to have that information and showing what our managed care and accountable entity partners have been able to do with that funding to reduce total cost of care while improving quality.
So, Director, thank you. I guess it's even if it was $10 that we got, that would like to see how we're getting a return on the investment, but it's upwards of $240 million, right? So how do we as a General Assembly, when somebody comes and asks us, you got this tranche of money, predominantly associated with accountable entities, doing a lot of good stuff, how do we communicate back to our constituents or our colleagues that the $250 million, this is where it got us? I'm not asking for an answer tonight, but it's the kind of, I think we talked about, I thought it was last year. These are the measures, these are the metrics. Oh, by the way, this is what we measured.
It's a great point, absolutely. We'll bring it back.
Thank you.
Senator De Palma.
I can say sort of more specifically, number one, information is always updated and posted on the EOHHS website. And two, we have an HSDP advisory committee that is a public meeting that meets every other month, I believe. So to members of the General Assembly or the public who are interested, those are open public meetings as well.
And we can share that information with them, can't we, Ben? Proactively.
Of course.
Thank you. Because I think it becomes one of those things that when the money is expended, we've addressed quality, accessibility, efficiency, effectiveness, whatever it is, and as the name implies, Health Systems Transformation Project, we've transformed something. So what did we transform from and to? So we can look at it and say, we spent the money wisely, and we can also look at it and say, we squandered it. Now let's tell us why. So, okay. Before I ask other questions by the committee? Okay. Director Shaffer, it was good to hear you. Before I left, I apologize, I had to step out. You talked about the work of RIPIN, Rhode Island Parent Information Network, and the work that they've done and the work that they took over that was originally, I'm not going to mention where it was before. I think we need to figure out how to wedge that back into the budget based on the work, having been associated with them now for probably at least a decade, going back to some, and I don't know how, this is not with RIREACH, but just about everything they do is top shelf. I think we need to figure out how do we restore the cut that was made. I know you said we want to do that. We need to figure out how to do that, and if the governor's willing to put a governor budget amendment in, that would help as well. But it's the work of RIPIN is, I think, invaluable to our state. So okay, let me move down. I'm trying to go through I highlighted a bunch of things and able to ask the questions based on that. I'm getting there. Other questions by the committee before we go on? Okay. So, Director, I also heard, so this is probably for the Secretary. It goes to the Director, but it's really at the Secretariat level. So, the Medicaid report is something I look for annually. And the last time the report was done, it was done late, And it was done because it was going to help provide the objective justification. And we heard Senator Bell mention earlier about a bill that Senator Corcoran had submitted. And I think it mimicked the language that Governor Raimondo had in her budget of 2019 that didn't make it over, this item didn't make it over the goal line. But the Medicaid report, and I think I recall correctly, Director Lisa Vera Weiss at the time, her Chief of Staff, Deputy Chief of Staff Lisa Vera Weiss, was responsible in putting that together. So in the future, I'd ask that the Rhode Island General Law calls Secretary, Rhode Island General Law calls out the Medicaid report being done March 15th. I know you're looking to try and move that this year. I guess the question that would ask for this, and I'm not looking for a specific answer now, but if we disregard Rhode Island General Law, which we have 2 years now, with regard to the report that was due May 15th of 2020 for 2019, and the report that was due, March 15th, and the report that was due March 15th, 2021 for 2020, what else are we not doing that, and I'll say regardless of the reason, I'm not certain there was a request that came, and we met last year in General Assembly after that, so shame on me for not pushing it harder last year, but understand it was a pandemic, but it was due on March 15th, so the pandemic began just after that. I guess Madam Secretary, why do we feel that we didn't need to do it?
I would not say that we felt that we didn't need to do it. I cannot speak about that specific report, to be honest with you. I will definitely go back and check what report exactly, because there's many reports that the UHHS Medicaid does. I will look at it. If there is a report that we are mandated to do by law and we haven't been able to comply, I can assure you it's because we couldn't do it on time, not because we disregarded the law. But I will check on it and get back to you with an answer.
Thank you.
I honestly don't know the specific report. I do not want to give you wrong information.
Okay. I guess the concern, Madam Secretary, is it's been 2 years, not just 1 year. So whatever the reason, I'd like to see what that is, and because it's an important report to have. So, okay.
No, you are right. Absolutely. I will follow up on it. As you know, I'm new to the UHHS Secretary family, and so I will go back and check and get back to you.
Okay. So the next question, this came up when we were talking about, I'm not certain, this is really the UHHS. I can't think, was it Matt Santa Croce as the marijuana czar, or whatever his role is. But we in the budget, we talk about the money for, and maybe Senator 70 already talked about it. If he did, please tell me. But there's adult use marijuana restricted receipts of $1.4 million, et cetera. And then we talk about the funds will be directed to the state's health equity zones to address the community needs. And I know Senator 70 has been a leader in ensuring that we get substance abuse investments made. Well, we have regional substance abuse task forces throughout the state. All of us do. Every senator and rep knows who their substance abuse task force folks are. They're very active in each of our communities. I know you talk about the HESs here, but I'd ask you to rethink the HES piece with regards to substance abuse. We have the task forces in each of the communities that do that now. I'm not certain why we're going to have another group do it when a group has already been doing it for much longer than the HESs have existed. So, comment, Secretary?
Sure, I can respond. I think there's two reasons that I would respond. The prevention task force are very much focused specifically only on prevention of drug use, as you mentioned. And they've been doing it for years, and they've been doing an excellent work at it. One of the reasons you didn't see it specifically mentioned in that funding was because the department, BHDDH department, receives federal funding and already invests, and we can give you, I believe you already gave that answer, millions of dollars already not millions, they already invest funding towards the prevention centers with other funding streams. In this specific case that you're mentioning, it's to work on the underlying causes of disparities, which is really what the health equity zones do. They work on the underlying issues. They work on issues around education, around housing. They work much more broader, systematic, system-wide issues and overall prevention, which is creating that infrastructure. What the adult use, recreational use was saying by investing in the health equity zones, it's to make sure that they use the health equity zones to do the equity work to address the disparities and to address the disproportionate impact on the society level that we have had with the drug use. The prevention task force do prevention work with children, with adolescents in schools, do education. This is a different level of work. They work together beautifully, have complemented each other, and in fact, for the past, since 2005, 2015, when we started with the health equity zones, they've partnered together, complementing the work that each one of them does.
Thank you, Secretary. I guess the question becomes, and like I said, Senator Seventy may have said this already, the substance abuse task forces have gotten virtually no money, virtually $0 from the state. It's all been federal money. I think you can go back, they should have gotten it, they really hasn't, but just that they were conspicuously absent in the description with regards to marijuana, which is a substance which gets abused. So I don't disagree that the HES is whatever role they follow and what they do, but the substance abuse task forces aren't even mentioned. So, thank you.
And Mr. Chairman, I haven't really had the opportunity to weigh in yet. You know, I mean, we addressed this last time this came up in one of the budget hearings, and you know, I have a little different perspective. As you're pointing out, the prevention coalitions around the state, it's a great idea. It's a good network. There's lots of good people working, and they are really seriously underfunded. Okay, and this was from the outset when the first series of contracts were first let for these groups to begin. They weren't given enough money to operate, and we're in a circumstance now where we have people who are highly qualified, very much underpaid, spending more time trying to chase grants and fundraise than to actually do the mission of the coalitions. And in my view, it's been pretty seriously mismanaged from a funding standpoint. BHDDH recycles the federal funds coming through. As we all know, most of that goes to the treatment side and the recovery stuff. We all know that that's practical reality. People are already sick. My frustration over the years has been there's almost no Rhode Island money going towards the prevention aspects of this, and the money that trickles through from the SAMHSA grants and all that stuff isn't enough to support these groups, and that has to be fixed. And what I'm seeing in the current budget plans does not do that. It's inadequate, and it ought to be looked at again. And I think any money related to substance abuse prevention should go to the coalitions. It should go to the younger group to try to keep them from going down this path in the first place. I think that's our only way out of this mess. And well, that's my 2 cents. Where you know, whatever money you want to put into the HESs, you know, that's fine. But whatever you do, find a way to better fund the prevention coalitions, because in my humble opinion, you're just screwing that up. You're missing an opportunity to really utilize this group. So get going.
Absolutely. I hear you, and we'll definitely look into it and how we can better support equally across the board.
Thank you. Thanks, Mr. Chairman.
Thank you, Senator. And I do know that is an issue that you've spent a lot of time on, and I think certainly you have my agreement that we need to make sure that we address that and continue to take action in that direction this session. Are there other questions or comments from members of the committee?
I have some more, if it's okay.
Senator Paula.
Thank you, Chairman. So, Director Shaffer, let's talk to hospitals a bit that may have been talked about already. I know you mentioned about I think you caveated it after. I was going to correct you, but I think you corrected yourself with regards to it's always been 6%. Well, in my 13 years looking at hospital licensing fees, it's been 6%, it's been 5.8, we looked at 5.2 maybe, 5.625. And I heard you say as well, how do we potentially with the rescue money address that, keep it at 5 for the fiscal year we're in now? Because at the end of the expectation is someone can say, well, you should know that it's going to be there because it's in the budget. Well, just because something's in the budget doesn't mean it's going to make it over the goal line. The budget gets passed in June, and the payment, I think, is due July 1st. So I think we owe it to our hospitals and what they've been able to accomplish and see themselves through from a pandemic perspective, the ability to weather that storm, so to speak, in the pandemic and where they are. And raising that to 6%, 11 and a half months into it, even though somebody say, well, we sort of told you 9 months into it that might be the case, is, I'll just say, short-sighted in that regard. Also, as it relates to the outpatient upper payment limit. And we've done this dance now for I don't know how many years. I think we've had this conversation last year. I had this conversation with your predecessor with regards to upper payment limit. And so the question is, and I saw the comment with regards to it's in the package that we're an outlier. So Director Shaffer, what's the measure or metric of why it should go away?
I think you're asking sort of why are we having, putting the outpatient UPL on the, as a recommended cut, if I understand your sort of, what's the sort of metric sort of question.
Yes.
As I stated previously, we look across the Medicaid budget for both savings initiatives and investments. And as we look across that system, we generally speaking try and prioritize primary care, pediatrics, behavioral health, those kinds of providers first. And as we look at the totality of the governor's recommended budget, often still based on other revenue factors, need to look for additional cuts. Outpatient UPL is one of them. Outpatient sort of rates are generally speaking higher even for Medicaid than the other areas, primary care and behavioral health, in particular prevention that I mentioned. And we also look at this, it's not particularly uncommon for states to not pay outpatient UPL. According to a 2019 MACPAC report to Congress, just 23 states made outpatient UPL payments. So we're certainly not alone in looking at this in difficult budget situations.
Okay. I guess as we move forward, given what we rely on from a hospital perspective and the status of our hospitals, how do we address that going forward? I want to talk about, I guess, a couple of, and there's a lot of good things in there. I know I'm talking about a lot of things and asking questions about concerns about some areas, but clearly in the long term, rebalancing, absolutely right on with regards to what we need to be doing there, all the right things from a long-term care perspective and being able to keep people in their homes and providing the services in the community. I think the challenge we have is getting those services in the community. It's okay that somebody stays in their home, but if we don't have the programs for somebody to get the services, then it's going to be a fool's errand with regards to what we need and expect without bridging that chasm of having the services in the community there. The specific question with regards to the under the $4.5 million in savings, we're showing, and I think I calculated it out to either 275 or 237, I don't have it in front of me, the 101,070 nursing bed days. So I just took that, divided by 365, and I forgot, came out to 200 and something folks for a whole year. How do we come up with that number of nursing bed days we'll have a reduction of?
Yeah, thank you for the question, and I'll admit at the outset, this is probably something I want to follow up with the committee on and yourself on, just because of the variety of different ways to look at it, depending on time frame you're using, depending on where you're baselining to. We had May caseload testimony this morning that resets the baseline. So I will say I'll give my best response now, and then happy to follow up with additional information. Generally speaking, what we are trying to do is really two things. One, we know that as a result of the public health emergency, and in particular, lower hospital discharges to nursing facilities, which comprise about 80% of nursing facility admissions, that nursing home census is down. So to put that in, not in a bed day perspective, but in terms of a rate, prior to the public health emergency, nursing facilities in the state operated about 94% occupancy overall. A couple months ago, that number was 92%, 93%. It's starting to tick back up these sort of coming months. I think right now we're at 75 or 76%. So one question we're trying to answer is how quickly is that going to, or slowly, is that number going to increase both overall for our nursing facilities and for the Medicaid budget? And that it depends on a lot of different factors, and particularly hospital discharges, as well as the continued churn in the nursing facility population, which is something that we see. That's sort of part one. Part two, with the investments that we've laid out, now how many individuals do we think we could divert or transition from nursing facilities should, to your point, more services be made available in the community? So that's the sort of balance that we work on. We believe that over time, really, I think through the entirety, quite frankly, of the fiscal year, that eventually nursing facility occupancy will return. But what we've seen, either individuals finding and making other arrangements and finding care once they learn about other options of care, be they assisted living, home care options, self-directed options, or even more concerningly, potentially going without care. So that's why we were proposing these specific investments in home and community-based services that we are, and we believe we'll be able to divert or transition. The number that's sticking in my head is sort of right around 500 Medicaid sort of members in its entirety into home and community-based services, whereas a previous testifier said, the average cost to provide care in the community is about 3 times less than in a nursing facility. So we'll be sure to follow up with more specific information in writing. I just want to make sure we are able to really define what terms we're using and what baselines we're using, given the 6-month updates in caseload.
Thank you, Director. Much appreciated what you've come back with on that. Under program integrity, I think I'm going to limit it to one more question after this, I promise. Maybe multi-part, but it'll be one more question. You talk about program integrity. So we're seeing a lot with it associated with fee-for-service, amongst other things, or managed care. I didn't see any mention here. I assume we can use this for Eleanor Slater Hospital. And what's happening there hasn't happened there, for that matter, based on what transpired over the last N number of months. So any reason Eleanor Slater Hospital wasn't mentioned as part of the program integrity effort?
I guess I would say that the program integrity budget initiative put forward by UHHS is separate. that effort, that third-party liability effort, is really, to your point, designed to make sure we understand which alternative payers, which other insurance sources Medicaid members might have in fee-for-service, and trying to utilize the best available data that we may not have. This is becoming increasingly important in the public health emergency, quite frankly, as individuals' insurance statuses have changed, and in some cases quite rapidly. Could it be extended to Eleanor Slater Hospital? That really depends on the specific nature of what Eleanor Slater Hospital is looking at. I have to look at that a little bit more closely, but we were looking at better ways to reduce costs without cutting services or cutting access, and within Medicaid, and third-party liability is one of those areas that we considered.
Thank you. So I was going to address just a comment on the right here that I have a question on the CNOMs, more general. On the right here, I concur with what we're doing here. I concurred with it last year. The concern is, will there be too many loopholes for employers to still effectuate what they effectuate today with either not paying people enough, number one, and some of that comes from the Medicaid report, by the way. Number two, cutting hours to just be under the number of whatever the case is. And number three, providing insurance for such a high copay or deductible that people can't afford it. So I'd ask, as we think about the right share going forward, the penalty may need to be higher. Some folks may just say, you know what, I'll pay the $2,500 or $5,000 and be done with it. I really don't care. I'm not going to, not the $5,000, that's for falsifying. We'll assume nobody's going to falsify any information, but filing it late, $2,500. I think we want to ensure people that want to be a part of it, because I think at the end of the day, the savings we've identified here could be higher. So, go ahead.
Just a brief comment on that. I just wanted to point out to the committee. I mean, what we're part of the initiative, certainly is the penalty that you spoke of. But we've also been working continuously with employers to improve our processes for the collection of this information, to make it as easy as possible for employers to participate. And we've seen the sort of fruits of that. So currently, sort of just under 600 employers participate in the program. They provide us the insurance rates that we need to do the cost effectiveness test and understand if it will be cost saving to the state. And we continue to reach out to those who aren't yet participating or for whom we may need more additional information. So I just wanted to add that, we do see certainly at least partial participation. About half of employers that we think have individuals on Medicaid we have rates for, and we certainly hope that we can continue to drive that number up.
Thank you. So the last question, Director, and this goes back to when I first heard about this with 4 or 5 Medicaid directors before, or 4 maybe. And it was part of the initial waiver we did in 2019. And one of the big advantages of that was I'll say somewhere in the neighborhood of $120 million associated with CNOMs, cost not otherwise matched, right? When I first heard that phrase, it's like, what's somebody telling us? And that was a good reason for moving forward with the Global Compact waiver in 2009. I'm not certain we saved any over the 5 years, but I saw in the budget here and the write-up in some areas where we're pursuing some CNOMs that we hadn't pursued before. So I'd ask that, and you don't have to answer tonight, maybe you can follow up later, or I'll follow up with you later. From a CNOM perspective, it's not that there's something that comes every year, but it's almost like there's the CNOM book, and somebody, based on what we're looking at, somebody happens to, I say this respectfully, not disrespectfully, because I know Medicaid, only a piece of it. You know it in and out. Somebody happens to stumble on, that's a CNOM we can use. Let's go do that. Well, how do we become more proactive with regards to the CNOMs, and whether it's this, maybe not this year, for next year, really look at a true evaluation of that in the prior to budget coming out for 22 for next year. I know it's now we're talking about the, 22 budget, I guess, but, or 21. But for next year, for 22, which is what we're on, how do we do that and look forward beyond this for a budget maybe it's going to come out in 23 that the governor puts out to really address CNOMs and how we benefit from those in a much more comprehensive fashion. So, just a suggestion.
Yeah, certainly can follow up more specifically on the CNOM point. I will say more broadly, what I take sort of part of your question to be is how do we look to other states' experiences? How do we look at what other states are doing to try and make sure that we have the best Medicaid program that we can have in Rhode Island? And I would say that's something that EOHHS and Medicaid try and do all the time. We try and be fast followers in any case that we can, and I think the community health worker budget initiative that's included in the governor's recommends is a really good example of where we've seen other states start down that path and seem to be having success with it, and where we want to emulate. Similarly, with perinatal doula services, another example of where other states are moving, where there's clear evidence, has been discussed, by numerous members and individuals testifying, and that we want to add our names to that. So whenever we're thinking about EOHHS policy making, we always try and take that into account.
Director, thank you very much, and I do want to say thank you. I thank the committee's indulgence on the questions in the late hour. I do want to thank you for the dual work as well. I know that was in last year's budget. We didn't include it. Hopefully this year it makes it over the goal. I know there's many folks out there across the state that are looking for that to happen. So thank you, Chairman. Thank you very much.
Thank you so much, Senator Palma. Are there any other questions or comments from members of the committee? Okay. Hearing none, I do believe that will conclude our hearing this evening on these budget articles. I want to thank the members of the administration for being with us this afternoon and into this evening. Thank you for supporting the hearing and also for your patience with some of our scheduling today. That does conclude our hearing. Senator Acosta makes a motion to adjourn, second by Senator Palma. All those in favor indicate by saying aye.
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 Well done.
And there's no one opposed. Thank you so much, everyone. Have a great night.